Good afternoon to everybody. My name is Antonio Colombo from Milano, Italy. I have Beatrix Vascherizzo, discussant Azari Rosman, Alok Fin, Abhishek Kumar, and Sudhir Ratore. And this session will be about transforming PCI, mastering and implementation of drug-eluting balloons. We have some objectives and goals of this session. If you can run the 2 slides I have. Here is the sequence. I think in the interest of time, I'm not going to read because you're going to see one after the other the presenters. So basically, this technology of SELUTION has a solid background. There are 2 prior studies, SELUTION first in men and SELUTION flow, proof of concept, and then this tremendously important study, large and small vessel, will be presented at TCT in San Francisco, and I believe will be a tremendously valuable step, not only for SELUTION, but for the DCB field in general. And then there are ongoing projects, one on small vessels in the United States, and one for in-stent restenosis, and then some other studies, LOVE-DEB and Malaysian registry. So let's not waste more time, just tell you that a lot of patients, 5,000, if we put together all other DCBs, the field of DCB is not at the beginning anymore, is an established field. Thank you for your attention, and let's start with the first speaker, Abhishek Kumar, moving toward DCB first approach in large vessel, LOVE-DEB study update.
Only one thing, remember, if you have any question, to use the application, and then we keep here all the questions.
Good afternoon, everyone. My name is Abhishek. I am a consultant interventional cardiologist in Wigan, which is in the northwest of England, near Manchester. And I'm also the chief investigator for the LOVE-DEB study. At the outset, my sincere gratitude to all the collaborators, including the individuals and the teams, particularly the BART's clinical trials unit, my research team at Wigan, all the co-PIs, and especially Professor Zaman, who's the co-chief investigator, the MedAlliance team, who gives wings to this study, and Jeff is sat here, so thank you. And finally, last but not the least, the Cordis team for the unflinching support to get it to this level. So I'm extremely grateful for this opportunity to share the platform with such learned and esteemed colleagues. I'll delve deeper into the LOVE-DEB, what exactly it is, later on during the session. These are the conflicts of interest and the disclaimer. So the big question is, why DCB? The angioplasty world, whether it is coronary or peripheral, is abuzz with drug-coated balloons, drug-eluting balloons. Why is that? And part of the answer lies with the problems with stents, which is well established that they accrue 2 to 3% annual event rate over a period of time. And that becomes particularly challenging in certain patient subsets and lesion subsets. So that's where the drug-coated balloons found their place because of the relentless drive of the physicians, academics, researchers over more than a decade and a half. The drug-eluting balloons have shown promise and established themselves as a safe and efficacious device, particularly in in-stent restenosis and small vessel disease. And that's where the majority of the evidence lies. So, but the question now is, which drug? There are 2 different types of drug. Which vessel, which lesion? And it's sort of become now the DCB wars, if you like. Pick and choose. But there has to be a scientific basis about the rational decisions we make for the patients. So thus far, the evidence lies in partly in hybrid approach, in small vessel disease, in-stent restenosis, and mostly with paclitaxel drug-coated balloons. However, the large de novo lesions form the bulk of angioplasty we do. And now we have got other option in form of the sirolimus-coated balloon, where the data is still lacking. Why sirolimus? It is a drug of choice for the stent platforms, and which has been well validated. We moved away years ago from using paclitaxel on our drug-eluting stents for obvious reasons, and some of which my co-presenter Dr. Finn will elaborate on later, but worth noting that the properties of limus drug, its versatility, its anti-inflammatory property, all that, and the wide safety margin, all that makes it a drug of choice for the stent platforms. It has been hard to get it on a balloon in a stable form up until a few years ago, and that's where this novel device came into picture. SELUTION drug-eluting balloon with a proprietary phospholipid membrane with micro reservoirs filled with sirolimus, which helps to impart or deliver the therapeutic levels of the drug in the vessel wall, which is released in a sustained way over a period of 90 days, which has been well validated in the clinical studies performed. And again, that will be commented on later. The profile covers the whole of the restenosis cascade up to 90 days. So therein lay this opportunity where we had this lack of data in the large de novo vessels and with the sirolimus balloon. And that's where this sort of a marriage happened, that we embarked on this study, and that's where the idea of LOVE-DEB emerged from. Now, people try and come up with some catchy names for their studies, and we hit upon this name LOVE-DEB. I don't take any credit for it. It was my co-CI, Prof. Zaman, who coined this term. Maybe Deb's got something to do with his past, but anyhow, this for more scientific relevance, how this LOVE-DEBs come about. So what exactly is the LOVE-DEB study? It's a prospective registry where we enrolled 306 patients across 9 UK centers over a period of 15 months. The criteria was that it has to be large vessel, more than 2.75 millimeters, de novo, and the SELUTION drug-eluting balloon will be the only drug delivery device. Patients with STEMI, cardiogenic shock, cardiac arrest, CTOs, patients who had mechanically treated calcium, all those patients were excluded. Patients who had stent implanted, excluded. The reason being that we wanted the pure data on the safety and efficacy of this device and in large de novo vessels, because otherwise all these permutation and combinations, as you know, can muddy the waters. These are the patient characteristics, particularly relevant, that nearly 30% diabetics, more than 60% of them presented with acute coronary syndrome, and rest of it sort of mirrors what we see in real world. Of particular relevance is the type of lesions. So these were by no means simple type A lesions. More than 60% type B, more than 50% of bifurcation. The median vessel diameter was 3, the median lesion length was 20 millimeters, and bifurcations nearly 30%. The residual final stenosis was less than about 10%. And remember, our primary endpoint was target lesion failure at 30 days and, of course, evaluation at 12 months. And this is the presentation of 30-day data. Guess what? TLF at 30 days is 0. This is quite remarkable. And this also sort of mirrors what has been seen recently in some of the peripheral studies, results coming from Japan and other recently presented at Charing Cross meeting, that efficacy seen even in peripheral vessels with SELUTION drug-eluting balloon hasn't been noted previously with other balloons in peripheral, and now the data for the coronary artery is also emerging. Why? Because this device helps to impart or deliver sustained and therapeutic levels of drug in the vessel wall, along with its other mechanistic properties of the drug in a safe and effective way, and that's why we see these outcomes. Of course, we will continue to evaluate this and present our 12-month data later, but to summarize the rationale for considering drug-coated balloons, both mechanistic as well as clinical. Mechanistic, because by doing that, by putting drug-eluting balloons, we avoid this issue of chronic inflammation, which is related to stents. Do you remember, sirolimus has anti-inflammatory properties also. The vessels, they are uncaged. They remodel uniformly. They maintain the vasomotion, so returning them to their natural state almost. We avoid the issues with stent fractures, the ISR burden, and in certain patient subgroups, particularly too young or older, patients who may have high bleeding risks, patients in whom we want to leave future therapeutic options open, either with percutaneous or surgical means. So those are all the reasons to consider drug-coated balloons. And why sirolimus drug-coated balloon? Because of the properties of the sirolimus drug. And why solution drug-eluting balloon? Because of this novel technology which delivers the drug in a sustained, in a therapeutic way to the vessel wall. And that's why we see the results that we have seen in the LOVE-DEB study. Thank you for your kind attention.
Thank you very much. So we have another 2 presentations, then we will open for discussion. Today is the case? Okay.
And I would like to finish off just showing a case example of the outcome of this balloon, what we see in the large de novo coronary artery. So this is a 61-year-old male, young, pre-diabetic, presents with anterior MI, preserved LV function, generally had a good functional status. Got brought to the cath lab, and this is his angiogram. Severe, critical distal LAD disease, and as you can appreciate, even angiographically, the vessel has calcification, and the disease almost extends up right from the distal segment up to this larger septal branch. So even visually, this disease is 70, 80 millimeters. Now, this was sort of a proof of concept at the time that how do we deal with it? Do we implant 80 millimeters of stent? The idea was no. Let's prepare the lesion well first. So pre-dilated with 2.5 balloon, and this was just post-pre-dilatation. Then we did an OCT run, and which will highlight that type of lesion, the mixed plaque disease, extending all the way from distal to the proximal vessel. And I'll break it down into the segments for the interest of time. And this is what we see across the vessel, and ranging anywhere from 2.75 distally up to 3.5 more proximally. So further prepared with a combination of non-compliant and scoring balloons. And we managed to achieve what we would call the lesion preparation recommendations by the expert group. Less than 30% stenosis, TIMI-3 flow, no flow-limiting dissection. And at that point, we felt it would be reasonable to just deploy drug-eluting balloon, solution balloon, right from distal to proximal vessel. And this was the final result. Now, some may get alarmed, and maybe 5 years ago, we would have been alarmed by some areas of dissection, but there's nothing flow-limiting, TIMI-3 flow, patient stable. We walked away from it. Brought him back after 6 months. So this is his baseline angiogram, and 6 months later, this is what you see. The vessel appears as good as new. Another view of it, baseline, and then 6 months. It is still healing. We did do the OCT run. The vessel healing was continuing even at the 6 months. But angiographically, it looks, there's no obstructive disease in here. And at 15 months, baseline, and then we go to the result. And if I purely just showed this picture at the beginning of this talk, some of you may wonder, what's the fuss? There was no disease at all. This is another view to confirm just that. So on this panel, if you look at this left anterior descending coronary artery, if we didn't say that this was treated with drug-eluting balloon, you would say, well, that has never been treated. This is normal coronary artery. And this is the sort of powerful result which we have seen in clinical practice, and that sort of validates what we've seen in our small study. Thank you for your kind attention.
Thank you. Thank you. Excellent way to start this symposium. Alok Finn will give us some rationale and pharmacology PK data about the new delivery system.
Okay, thank you, Antonio, and thanks to the organizers for inviting me to talk. I'm going to go a little bit more on the non-clinical side into the basics of the balloon itself and how it all works. These are disclosures. Sirolimus, as you all know, first-turn rapamycin was discovered in South America on the beaches, actually, and it's been first used in organ transplantation for preventing organ rejection. It was approved by the FDA for organ rejection in 1999, but then, as you all remember, with the Ravel trial on the Cypher stent, 2003 was a real revolution. And I think we've put it on almost every stent after that, but for the drug-coated balloons, that's a more of a novel use of it. And the previous speaker did highlight some of the differences. I just want to point out a little bit that, of course, sirolimus is known to be more safe. In the coronary, it is the predominant drug used. It's got a really good cytostatic effect, paralyzing smooth muscle cells. Safety margin is much wider than for paclitaxel. Therapeutic range is fairly wide. It's very good anti-restenotic. It's an anti-inflammatory, as mentioned. I mean, the problems with sirolimus, of course, are that it's less lipophilic and it's complex, and it doesn't really absorb well, and its tissue retention is very short. So therefore, the complexities of the balloon. So in order to make a sirolimus-coated balloon, we really have to do three things. Enhance the tissue absorption of the drug. First of all, get the drug to the wall, and then have the drug stay there, be retained there. Remember, for at least 60 to 90 days is really what we want for maximum anti-restenotic effect. And of course, we want to protect the effect of drug-coated embolization. We certainly don't want the crystals from the balloon or the balloon components to go downstream and cause damage to non-target organs, as we'll discuss. And we discussed the makeup of the balloon. I just want to say just two things, which is one is there's this proprietary phospholipid coating, which really is meant to enhance drug transfer, protect the drug from going into the bloodstream before it's transferred to the wall. And then microreservoirs are really the mechanism of how this drug stays. It's really sirolimus intermixed with PLGA polymer, which is a biodegradable polymer which degrades over time, allowing sustained release. And this is just the overall schematic of that, but you can see here these microreservoirs can be seen on high-resolution SEM in the arterial wall of a rabbit here, in this particular example treated with the sirolimus-coated balloon. This is what it actually looks like. So the study that I'm going to present is a novel study we haven't presented anywhere else. It's the largest comparative pharmacokinetic study with 36 animals over 4 time points, and we really wanted to compare in this study the SELUTION SLR DEB to another drug-coated balloon, the Magic Touch DCB, to Xience. Now, why did we use Xience? Of course, it's the gold standard, I would say, for drug permanence in the wall. If the balloons can copy or phenocopy Xience, I think it predicts success. And this is really a pharmacokinetic study to make sure that we're getting adequate levels of drug into the wall. So 3 devices tested. I mentioned 12 animals per device. 2 de novo vessels were treated. This is a de novo study. De novo vessels were treated per animal, 4 time points. I'm going to present data here from the 7, 60, and 90. The 28-day data is still pending. I want to tell you that. And this was a study done under IVUS guidance, where the vessels were first undergone IVUS, and then the balloon was sized 1-to-1. And what you can see in this pharmacokinetic study is you can see the Xience and SELUTION products themselves, their pharmacokinetics are excellent. They basically result in sustained levels of sirolimus in the arterial wall out to 90 days. SELUTION perhaps a little less than Xience, but almost on the same trajectory. The Magic Touch did not do quite as well. You can see quickly by 60 days there's a significant drop-off in drug levels, and by 90 they have become subtherapeutic. What about concentration of drug in the downstream myocardium? Of course, we do want drug in the wall, but we don't want it in the downstream myocardium. You can see that stents themselves perform extremely well when it comes to that. There's really no drug detected in the downstream myocardium with Xience. You can see with solution, there was 130 nanograms per gram, which is much less than with Magic Touch. So I think very, very good data in terms of the drug got to where it wanted to go, and it didn't, too much of it didn't go downstream. And in a previous study, we had shown, looking at embolic effects, this time we randomized animals to coronary arteries to either solution, Magic Touch, or agent, or POBA. And you can see in this particular study, we looked at the downstream effects on the heart. Was there any impact of balloon coating emboli? And you can see here, the agent balloon was the only balloon to really cause downstream myocyte necrosis and scarring, and they had the most number of emboli downstream, with solution and Magic Touch being next, and with the least for POBA, as you might expect. And of course, the downstream myocardium drug findings phenocopied what I just showed you. The most for agent, which I didn't show you, but next for Magic Touch and the least for the solution SCB. So nice to reproduce previous data. And this is just an example of histopathologic findings. You can see here that there were small emboli found with both Magic Touch and solution, but you can see large areas of scarring for paclitaxel-coated balloon agent, as well as evidence of myocyte necrosis and fibrinoid necrosis of small arterioles with inflammation. So I wanted to just finalize by saying that really, there's really no DCB class effect. DCBs each have to be examined based upon their own particular makeup, the type of drug, the dose, formulations, excipient, coating. I don't think we can just say sirolimus-coated balloons and standardize that across the board. Each one has to be examined on its own merits. So in conclusion, I think I've shown you the solution DEB, the drug-eluting balloon, demonstrated sustained and controlled sirolimus release, not unlike the elution curve of Xience, which I think is very good predictive data. Magic Touch showed a rapid decline in drug levels, falling below therapeutic levels after 60 days. Drug in downstream myocardium was the least for Xience. Solution was next, which is good news in terms of specificity for the wall. And the pharmacokinetics of solution DEB demonstrates sustained drug in tissue and should enable desirable clinical outcomes without the need for a permanent implant. So with that, thank you for your attention.
Thank you. Thank you very much, Alok. We have another presentation, and then we open for discussion. Azhar Rosman will present the experience in Malaysia with SELUTION.
Thank you very much, Prof. Antonio. This is indeed a big honor for me to present this on behalf of our investigators in Malaysia. Let me just give you a background, and of course, Codis for the support that they've done in regards to making this a success. But perhaps I can start by giving a background of the sort of patients that we have in Malaysia, and these are the sort of profiles that probably the biggest challenge for intervention exists, which is the high incidence rate of wrist stenosis, very diffuse disease, very early onset, and very aggressive disease. And vessels are usually coexistent with underlying diabetes, which is, of course, often poorly controlled, high cholesterol levels. And our onset of disease is very young, with bypass surgery occurring even as young as the age of 21 years old. That seems rather unusual, but you'll see in a short while the sort of profile that we have as opposed to the incidence of diabetes that Prof. Abhishek has actually shown in the United Kingdom. So I don't have any potential conflicts of interest, and I hope that I'll be able to share with you the results which will determine the sort of balloons that you use in the sort of patients that you will encounter. So I think, as previously been mentioned, these are basic introductions, which is basically to leave nothing behind, to preserve vasomotor function, and of course, importantly, to give you the option of coming back again at some later date if and when wrist stenosis or disease progression should occur. So this is a trial, or rather registry, to look at how well the sirolimus drug-coated balloons actually work. So there's been some pushback among our colleagues, in fact, in Malaysia and many parts of our Asia, for example, with regards to the effectiveness of sirolimus compared to paclitaxel. And I think this is a trial, a registry, which is probably going to shed some light in regards to the effectiveness of the technologies that have been discussed previously. So we've got about 100 patients using this solution DEB. We call it SLR from now on. and pseudonomous releasing. And of course, our DEB use after successful lesion preparation is to see that they have no flow-limiting dissection of any severity, a symptometry flow, and a residual less than 30% stenosis, standard requirements. Major exclusion criteria, again, no cardiogenic shock, urgent PCI, or out-of-hospital cardiac arrest, and not used for ISR. So these are just de novo lesions. And the primary endpoint, standard lesion failure, TLF at 1 year. Secondary endpoints are device success, lesion success, and procedural success, and MACE, major adverse cardiac events, and of course death. So the follow-up is by telephone or by clinical when they are being seen in the clinic, and they're 30 days, 6 months, and 1 year. So let's look at the patient profile as I alluded to earlier on. These are the sort of patients that we have, 62 years old mean age, and of course diabetes 65%. Remember the figure that was shown by Prof. Abhishek, which was about 29%. So ours is 65%, and look at the hypertensive, 88%, hyperlipidemia, 98% of these patients angioplastic. Many are current smoker, but not as much as it used to be. And of course, many of them have got stable angina and some unstable angina, non-STEMI. So many of them have got half and half severe single vessel disease. Lesion length, lesion characteristics of these 130 patients treated by DEB. Lesion length is about 31 millimeters, reference vessel diameter, so these are on the smaller side, 2.7. There are some bigger vessels which we've handled, we'll show you in a minute. And they are moderate calcification, 12%, severe calcification, 6%. This is by assessment, visual assessment. Diameter stenosis is about 83%. And provisional stenting 5%, which is stented because of unsatisfactory results, or that there's flow limiting dissections, or that we need to get suboptimal results to be corrected. The vessels involved mainly the LAD, circumflex 24, PDA 5, 21, and our diagonals, OMs, and RCA 26. Again, the procedural characteristics of these 100 patients. Procedural duration is about 68.3 minutes. Lesion preparation, none. Here's what I would like to draw your attention to is many of them are using lesion preparations with scoring balloons and cutting balloons, 89% or 92 when you add the cutting balloons together with the 3% cutting balloon. Semi-compliant balloons also a fair number, and non-compliant balloons also a fair number. So you can see the sort of balloons and devices that we've used to prepare the lesion well for drug-coated use. And this is standard practice in our setup in the National Heart Institute. And of course, minimal residual stenosis within the requirements of the trial. Device success is good, lesion success, procedure success good, and no perioperative events. The clinical outcome at 1 year is about 2% target failure. This is restudied, and there's some minimal restenosis, but significant enough for them to be treated with drug-coated balloon. Again, death 3%, but not related to any cardiac issues apart from one heart failure, which is already ongoing. And of course, 7% MACE. No procedural or device-related deaths. So this is an example of the sort of lesions that we've been used to handling, and you can see in panel A, the lesion disease appears, the whole vessel appears diseased, in fact, and then we've used the balloon on the panel B, and subsequently lesion treatment, and then restudy again, because this is one of the patients that came in with chest pain again, but you can see it's not because of the vessel involved, and nor were there any other vessels involved that can cause the chest pain, so it's probably microvasculature disease. And the study shows a positive valence, you can see in the distal right coronary artery, and it has occurred as early as 7 months and perhaps even earlier. So I think the maximal growth will continue to accrue over a period of time, and I think this is the major strong point about this particular balloon, in that it is able to deliver the positive remodeling over a period of time. Now, the SELUTION SLR DEB in this observational cohort, although 1 year has very excellent efficacy and safety, particularly given this cohort's high risk comorbid conditions, and of course the nature of the vessels, which are diffuse, often long lesions and small vessels, and have a leave nothing behind strategy, which may provide benefits by avoiding chronic inflammation associated with a metallic implant, maintaining physiological vessel motion and pulsatility, and avoiding stent fractures and treatment and burden of ISR, amongst other things I might add, etc., to that. Broader and longer-term follow-up is required, of course, and investigating the specific patient cohorts, in particular the South Asian as well as Asian patients, and I add South Asian and the Asian as distinct from the Far East Asian, which are somewhat different phenotypically in terms of their coronary vasculature, patients, which I think in this very promising drug-eluting balloon, we hope will occur in the near future. Thank you very much.
Thank you. Thank you. Unfortunately, we are behind 5 or 6 minutes, but I think we should have 2 or 3 questions. Please, short questions and short answers, because we are late, and I will ask the next speakers also to respect the time or even shorter.
There are some questions from the participants. There are few to Dr. Kumar. They are interested in the criteria to cross over to stent. That means you enter the case after predilatation. When the predilatation is succeed, then you use drug-eluting balloon, and then you enter the case. Or when you fail with predilatation, that patient is not included in the registry.
So patients included in the registry were the ones who met the expert recommendation regarding the lesion preparation. And that's where they've had to satisfy that it was a large de novo vessel, and after adequate lesion prep, that's when the drug was delivered.
And then there are 2 questions for Dr. Rosman about evaluation of dissection. What is because they don't understand very well the flow limiting dissection is the main, or you use some FFR or something like that to evaluate dissection?
All right, excellent question. We have installed a QFR flow dynamics assessment for flow, and we have an assessment, a minimum of 8.0, but usually if satisfactory, anything above 8.0, below that, then we see that there is flow issues. Visually, the dissection itself, of course, helps whether or not they are, type more above type C, D, E, and so on. But usually we are guided by flow, ECG changes, symptoms, and so on. That gives us an idea of whether or not we should stent, and some of these vessels do. We allow for some time to look at recoil, for example, and then repeat the injection again, and if necessary, then we stent. Those are the clinical indicators.
Any other question?
There are several questions. There are one to Dr. Finn about paclitaxel and limus, if he thinks that there is an impact, clinical impact, using one drug or the other.
That's a tough question. I think that there is probably clinical impact in terms of, I think both these products are probably going to reveal good results, but I think the clinical impact still is being understood in different tissue beds. So coronary might be a different result than below the knee. No drug-coated balloon has succeeded below the knee. So we really have to see whether paclitaxel has already been tried many times, as you know. Will sirolimus succeed where paclitaxel fail? I think that's one of the implications of the embolization data I showed you, but that's going to require further studies.
Okay, I think we move to Sadit Rator. We'll present some cases, about 8 minutes for this.
Thank you, Antonio. Thank you, panelists, and thank you, Cordis, for the opportunity. So my topic is transformation of drug-eluting balloon PCI in my cath lab. Case-based journey. I'm an interventional cardiologist practicing in southwest of London. So no conflict of interest. I'll dive in straight with my case presentation. It's a 63-year-old gentleman with standard risk factor, which I performed 2 years back. Patient had a previous coronary artery bypass surgery 6 years back with patent, and patient presented with stable angina. The lima to LAD was patent, but the saphenous vein to the circ and right coronary artery were occluded. And patient had preserved left ventricular function and positive exercise tolerance test, positive at moderate workload. So the plan for this procedure was to do a PCI to a native left main stem, circumflex, and the proximal LAD going into a large diagonal branch. So I'll just show you the baseline angiogram for this patient. So you can see there is a large diagonal branch, and the proximal LAD is occluded, which is supplied by the left ventral memory artery. There's a severe lesion in the distal left main stem going into the circumflex, and the graft to the circumflex is blocked. So this procedure was done a couple of years back. So I decided to obviously wire both the limbs and do the lesion preparation. And this was the angiogram after dilating both the limbs with a non-compliant balloon 3.0 and 2.5 non-compliant balloon at high pressure. So obviously the main lesion was in the circumflex branch, but there was a lesion in the diagonal as well. We treated distally with a stent, and I decided to treat this patient with a 2-stent strategy in a DK crush format, with main stent being left main to left circumflex, and the stent in the diagonal territory was crushed. And this is how the procedure was performed. So this, obviously, first the stent was placed in the LAD, which was crushed into a diagonal, and then the left main to circumflex stent was done, and followed by a port, and this was the final angiogram, and the patient was discharged home. So I'm trying to show you a case, how it transformed me to using drug-eluting balloon in my cases. So this patient then presented sadly 8 months later with acute coronary syndrome, high troponin, ongoing chest pain, widespread inferolateral ST changes. And this was the angiogram for this patient at this time. So the patient has had a DK crush done 8 months back. So he's got a severe occlusive instantary stenosis in both limbs. So obviously the option was to treat him with the percutaneous option here. Obviously his lima is still working to the LAD, patient is symptomatic, and the lesion was quite difficult to wire, severe instantary stenosis. It was wired using some XT and Gaia 2 wires, wire exchange, and then both limbs, LAD and the circumflex, were treated with non-compliant balloon 3.0 and 2.0. So, and this is how it was treated, and you can see then non-compliant balloon was done and the port was done. So then after treating that, obviously we achieved a good result. Then I decided to treat, obviously there are not many options here. You can put another stent, but I decided to treat with a drug-eluting balloon, which was SELUTION SLR DEB in this case, 3.020, 3.5 by 30 in left main to circumflex. And then kissing balloon was done after that with the same balloon, and the report was done, and we achieved a good result. And this was the final angiogram. So this is the case just to demonstrate my journey through one case, how obviously I tackle these kinds of cases, maybe going forward. So now I present, obviously you all know this, there's a randomized trials meta-analysis done on the randomized trial, which shows that the two-stent strategy as compared to one stent strategy in complex bifurcation left main, there's significant 31% reduction in mortality. So I'll not go too much into this, and this has kind of changed my practice now in my cath lab. So I will now do the main case presentation, and then we can have some discussion how we treat it, and then I will show you how I treated it. Similar kind of case, coincidentally, 74-year-old female, standard risk factors. She's had a previous coronary artery bypass surgery again, and she's got a failed grafts. She's got a severe coronary artery disease, preserved left ventricular function, and RCA had had a previous stent, which was treated 6 months back. She continued to have ongoing angina, and she came for a coronary angiogram. And this was these are the coronary angiogram. If you see in different views, he's got a severe left main stem going into LAD, and he's got a moderate to severe disease in the proximal left circumflex coronary artery as well. She's a quite dominant artery. There is a graft which is working on one of the vessels, but it was not functional. So this is my case, and I can show you that there's an intravascular ultrasound done from left main into LAD, which I will keep running. It's got a severe calcific lesion with the ostium of the circumflex also moderately involved, concentric severe calcification, short left main stem, true 0, 1, 1, 1 bifurcation. So I'm going to stop here, and maybe there's a time for some discussion.
Okay, any proposal from the audience or from the panelists?
I think it's a true bifurcation lesion. Post-bypass patient always has a lot of calcification, so it's a really complex case to manage. It will not depend on drug-eluting stent or drug-eluting balloon, but I think to me the provisional T-stent strategy could be the best approach, and then to treat the side branch with drug-eluting balloon could be my option.
Okay, I think it's a very rational option, but in my opinion, this decision has to be made after lesion preparation. So
yeah, lesion preparation, yeah.
No question that you can be very optimistic to use one stent, but the final answer comes after lesion preparation. So here you highlight what you did, or
yes, so yeah, I can show you what I did. Yes, so obviously these are the valid questions, whether we do a single stent, upstream 2 stents. So obviously we decided to go with a provisional approach, wire both the limbs, left main into circumflex and left main into LAD, and do the lesion preparation in the LAD. The LAD lesion was, left main to LAD lesion was very calcified and severe, and then do a crossover stenting and then assess the side branch of being a dominant circumflex coronary artery. We'll be respectful for that to see if we need a T stent or need to use a second stent in the T format. That is the main option. You can do a reverse crush as well, or we use with a plain balloon angioplasty to a kissing balloon, or with a drug-coated balloon. So this is the kind of, obviously as expected, we started with a non-compliant balloon, 3.5, non-dilatable lesion. So, and you have seen the intravascular ultrasound already. It was circumferential lesion in the proximal LAD. Actually, it was in the distal circumflex, distal left main and proximal LAD. It was non-dilatable, as you can see here. So we decided to use intravascular lithotripsy. 3.512 balloon was used. So we have to deliver a lot of pulses to get this expanded. And it wasn't, obviously, after the intravascular lithotripsy, also the lesion was not fully yielding. So we have to use a high-pressure, non-compliant OPN NC balloon, 3.5 by 15, up to 40 atmospheric pressure to achieve some kind of a satisfactory pre-dilatation, as you can see here. Still, the wire bias is there, and there is some under-expansion. So this is a kind of angiogram. I know it's because there was some damping with the guide catheter into the ostial lesion. So after lesion preparation with the non-compliant balloon, intravascular lithotripsy, and high pressure balloon, we have not done any dilatation into the circumflex ostium. So it's all done in a provisional format. So there was. You can see here in the circumflex ostium there is a plaque shift or a carina shift, you can say. And but we decided to do a crossover stenting here because of a very short left main. We decided to put a left main to LM LAD 3.5 by 20 stent. And this was the result after the stenting, obviously. So we can, if you want, somebody wants to comment on it.
I think we have no time. We have only one.
So obviously there's a side branch, a lot of plaque shift, ostial disease. So we decided to just cross over into the circumflex. We did a crossover. There was some issue about the wire going behind the stent, but we crossed over. We confirmed the wire position with the intravascular ultrasound, and we did an opening in the stent with a 2O balloon first, and then we decided to treat this with a bigger balloon. And then we decided to treat the side branch with a SELUTION SLR drug-eluting balloon, 3.20, and a KBT performed by 3.5 by 30. Report was done. And this is the kind of pictures we got. And this was a final coronary angiogram. So we received a pretty good result. So obviously we decided to treat this patient in a simple format, using a side branch, using a drug-coated balloon. But the proof of the pudding is in the eating. So this patient, for some reason, has come for a follow-up. So this is a follow-up angiogram in 6 months for the same patient. The ostium continues to look good. It's a large circumflex. And we've got an angiogram follow-up for 2 years as well for this patient. So it shows continuing good result in the left circumflex ostium. There is some mild ISR in the proximal left ventricular coronary artery stent, which we have to put up with 2% year-by-year increase. So in conclusion, my take-home message is that left main large bifurcation are common, and studies have shown adverse outcomes with 2 stents as compared to 1 stent. And drug-eluting balloon alone or a hybrid strategy is emerging and gaining popularity and very valid to be used in these kinds of lesions, and have shown a better outcome with drug-eluting balloon more recently. Obviously, intravascular imaging, adequate lesion preparation, and physiology is very important. So I'm going to stop here now, and I'm happy to take any questions.
Thank you very much. Unfortunately, we have no time left, so the take-home messages is do more cases, another couple of thousand, and we will draw conclusions.
Thank you.